acids. We're also going to give things like Tagamet and Zantac, and these are what we call H2 antagonists. Now, an H2 stands for histamine 2. These are receptor sites that live in your stomach. Okay, every time you have an allergic reaction, when an ant bites you or when a mosquito bites you, you know how the area right around the mosquito bite turns red? Okay, that's a direct result of histamines that respond, and it causes inflammation. Well, what we want to do here in your stomach is to stop the histamines from being formed. It causes an inflammation, makes it red and irritable, and causes pain. So we give H2 antagonists to stop those H2 from the histamine from being produced, so your stomach doesn't get inflamed and painful. So that's why we give Tagamet and Zantac. We give anticholinergics like probanthine and Robenal. And why? What does that do? It diminishes secretions, right? So we don't want as much acid to be produced, so that's why we give that. We give anti-secretories like Prilosec and Prevacid. And for the same reason, we want to stop too much production. And then we give Carafate. Remember yesterday we talked about Carafate or Sucralfate and milk of mag or Mylanta? Remember that? Okay, which one do we give first? We give the Carafate first, right. Okay. And we'll also give antimicrobials because we want to prevent any complications of a possible infection. If the surgery is needed for peptic ulcer, you may see two major complications. Number one is a dumping syndrome, and number two is a B12 deficiency. And with dumping syndrome, basically what happens is severe palpitations and sweating, and blood pressure may drop, okay, and he just feels really dizzy. Because what happens with a dumping syndrome is that everything that it goes into your stomach dumps right away, immediately into your intestine. Now, usually it goes on a progressive, slow progressive fashion, but with dumping syndrome, which is a complication after gastric surgery, you might see this. Okay, there's the question in NCLEX that talks about a Billroth 2 procedure. Well, the Billroth 1, and everybody panics because they go Billroth 1, Billroth 2, exactly what is it? It doesn't matter, folks. All you need to know is that the Billroth 1 and the Billroth 2 are gastric surgeries. It means that they cut out part of your stomach and anastomose the intestine to it. Okay, so when you remove part of the gastric cavity, you are removing also the parietal cells that contain your intrinsic factor. And what does your intrinsic factor do? It absorbs B12. So if you're going to start removing these parietal cells that produce intrinsic factor, guess what you've just done? You may have fixed his peptic ulcer, but now you've just given him a B12 deficiency. And if that happens and he gets pernicious anemia, guess what? That person's going to have to be on B12 shots for the rest of their life. Okay. Dumping syndrome, as I said to you, is caused by the rapid emptying of these contents. How can we avoid dumping syndrome? Well, what we want to tell them to do is to avoid eating a lot of high carbohydrate foods and lots of fluids at meal times. We don't want him to be, actually laying down is good after meals. Sitting up is not good, so we don't want him to be sitting up, after meal times. We don't want him to be drinking a lot of fluid around his meal times also. Okay, we want to give and tell him to eat slowly. That also helps as well. All right. Diverticulosis. Diverticulosis is where you have multiple diverticula. One diverticula is an outpouching of the intestine. And so if you think about your intestine, it's got all these rugae, right? All these lovely little rugae, and then all of a sudden you've got an outpouching. Well, when you have an outpouching like that, the chances are that if you eat nuts and berries and all those wonderful things, a nut or a berry may get caught in one of those pouches, and that can cause excruciating pain along with a possible infection. So people with diverticulosis or diverticulitis, you want to tell them to avoid nuts and berries. Okay, these people are already going to be complaining of severe cramp-like pain and lots of flatus, and we all know what flatus is. Yes? Good. We all know. Don't anyone raise their hands and tell me they don't know what it is. Please. Nausea, you'll see that. They will have irregular bowel patterns, and sometimes some of them will actually pass out blood or pus. Yeah, I know. And fever. Okay, so diverticulitis, diverticulosis is pretty much the same signs and symptoms. Diverticulitis is an inflammation of a diverticula, though. A diverticula is an outpouching. Diverticulitis is the inflammation of that outpouch. So you want to avoid, as I said, nuts and berries. The treatment and the diet is exactly the same. All right, ulcerative colitis. This is probably, I can think of, this is a fate worse than death. It's an ascending inflammatory disease of the colon and the rectum. So it starts in the colon and the rectum, and it goes up. It goes up your intestines. It's extremely painful. These people are passing 15 to 20 watery, very mucousous, bloody stools a day. They are extremely thin. They've lost a lot of weight. Okay, why? Because nothing stays in the intestine for them to absorb. They cannot absorb any nutrients. They've got a fever because, remember, with any inflammatory process, you've got a fever, right? It is warm. It is hot. So they've got a fever. They've also got severe abdominal pain. So how do we treat ulcerative colitis? Well, because of the weight loss, we say please eat a lot of high protein, high calorie foods, low roughage, because why? They don't need roughage. Trust me, 15 to 20 stools a day, they certainly don't need roughage, okay? They need to retain as much as they possibly can. Lots of psychological support because of the pain, because of the discomfort, and because also they may very well end up with a colostomy. So, it's really important. They will get steroids. Now, remember how we talk about steroids and we think, well, 5 milligrams, 10 milligrams, 20 milligrams, and then you taper, right? These people with ulcerative colitis can be on as much as 60 milligrams BID for the rest of their lives. Yes. So imagine the mood swings that they're going to be going to be experiencing. Certainly. They're going to have severe mood swings because of this high dosage of steroids that they're going to be taking. Antibiotic treatment, my gosh, let me tell you, Keflex is their best friend. Yes, because anytime and every time they have just a little bit of something, they're put immediately on an antibiotic. They'll give sulfonamides, which is an antibiotic, with severe attacks. So you're going to see very aggressive treatment with ulcerative colitis. You're also going to see aggressive treatment with Crohn's disease. With Crohn's disease, you have cramping after meals. You've got, again, the weight loss. You've got the anemia. You've got chronic diarrhea also, right? Same as with ulcerative colitis. You've got a temperature. Okay, with Crohn's disease, though, what you've got to watch for is a possible perforation of the intestine. Actually, you also got to watch that with ulcerative colitis. There's a possibility of a perforation of the intestine because, remember, it's an ulcer. Okay, so you've got to watch for that as well. How do we treat Crohn's? Well, usually an ileostomy. Okay, and we're going to talk about ileostomies and colostomies in a little bit. Again, low residue diet. They do not need a high residue diet because they're also going to the bathroom very frequently. A bland diet, lots of iron, lots of vitamins, lots of high caloric and high protein foods. They also will get sulfonamides. They also will get anti-inflammatory drugs, but they will get things like steroids as well. You will not see them taking stuff like NSAIDs, because NSAIDs is irritating to the stomach, so you don't want to do that. You know what NSAIDs are, right? Non-steroidal anti-inflammatory drugs. They will get antidiarrheals, and so actually will people with ulcerative colitis. But they get the granddaddy. They get things like Lomotil. Forget the other stuff. They get the granddaddy of antidiarrheals. They'll get anticholinergics, like atropine. And atropine actually also works as an antidiarrheal. All right, what is an ileostomy? I just said that with Crohn's, you might see an ileostomy. With ulcerative colitis, you may see a colostomy. Well, an ileostomy is when you take a portion of the ileum and you bring it through the abdominal wall. With an ileostomy, it involves the removal of the colon and the rectum. So that means, therefore, it's permanent. Yes? Because once you remove the colon and the rectum, you can't go back. All right? So ileostomy is permanent. Preoperatively, we're going to give neomycin enemas because we want to sterilize the bowel. We'll give blood and fluid and protein replacements as well. Okay, because we want to build the person up for the surgery. Remember, they've already lost a lot of weight. Post-operatively, it's routine. And what are we going to do? Bowel sounds, and bowel sounds, yes? And document your bowel sounds, all 4 quadrants. What about colostomies? Well, a colostomy is when you bring a portion of the colon through the abdominal wall. And you've got 2 kinds of, and preoperatively it's the same, you've got 2 kinds of colostomies. And we'll cover that in a second. Let's talk about, we did that stoma, okay. Okay, let's talk about a colostomy and an ileostomy. Post-operatively. Post-operatively, what you've got to do is what? Note the first flatus. And how do you note the first flatus? You look at the bag and see if it's inflated. If it's inflated, then he just passed gas. Right? Isn't gas just what it is, air? So you look at the bag. If it's inflated, then he just passed gas. You note the time. Okay? The time that you observed it. When a person has an ileostomy or a colostomy, there are certain diets that we want to advise them on, okay? There are some odor-causing foods, things like cheese or garlic or eggs or fish, asparagus, onions, heavy spices. These all cause odor. Now, what NCLEX does is that they're going to ask you, the focus of the question will be, your patient has a colostomy and is concerned because his flatus is extremely odorous, so which of the following foods would you advise him to avoid? Then you would pick from the list of odor-causing foods. If, however, they said, you know, he's got a lot of flatus, all right, and he wants to avoid the flatus portion, then you go from the list of gas-forming foods. Okay, and gas-forming foods include everything from the cabbage family. Here is my happy broccoli, onions, peas, corn, radishes, string beans, okay? Beer and champagne, folks, those also cause gas. If, however, they say, you know, that he wants to take, he's got too much diarrhea, and what kind of foods could he take that would harden up the stool, then you give him this list, okay? Hard-boiled eggs, cheese, sugar, liver, yuck, rice, bananas, applesauce, toast, gelatin, concentrated broth, meat, chocolate. Chocolate's constipating. Did you all know that? Now you do. So you know some of these things cross the list, right? They cross over from one list to the other. It depends on the focus of the question, is I guess what I'm trying to get to. All right, you have a patient who had a stoma put in. What is your nursing responsibility? Well, immediately post-op, you've got to check the stoma height. You've got to check the stoma color, right? You also have to check and make sure that the bag is applied properly, because there will be a bag. You want to inspect everything. You have to understand that you're going to teach the patient that this bag needs to be changed every 5 to 7 days. You also need to know that obviously if it's leaking, you're going to change it immediately, right? You're not going to wait. The bag, the stoma bag, the colostomy or the ileostomy bag needs to be emptied every 4 to 6 hours. Don't let it sit for longer than that. Don't, because then you're going to have a backup of stool, and if it hits the skin, that's not going to be a good thing. The area around the stoma, what should you use to wash it with? Soap and water is fine. It's not a sterile technique. Okay? The skin barrier needs to be applied to dry skin. And when you fit the appliance around the stoma, the opening should be only 1/8 of an inch larger than the stoma. Again, you want it as close as possible to the stoma because you want to avoid excoriation. All right, there are different types of colostomies. And this is an NCLEX question. There are different types of colostomies. There's the single barrel, okay, and there's the double barrel. The single barrel means there's only one stoma. And so that single barrel means that the distal portion of the bowel has been removed. So remember we said the ileostomy, right? With the ileostomy, we remove